to spend this time with us. My name is Pascale Allotey, and I have the privilege to serve as Director of the WHO Department of Sexual and Reproductive Health and Research, which includes the WHO, UNFPA, World Bank, UNICEF, and UNDP Special Program for Research, Development, and Research Training in Human Reproduction, HRP for short. I want to first of all thank USAID Momentum for organizing this conversation and for their commitment to reducing maternal mortality by expanding access to life-saving maternal and newborn health care, ensuring women receive quality and respectful care, and meeting the unique needs of vulnerable women and newborns in fragile settings, and applying practices that work best to help mothers and infants reach their full potential. A few weeks ago, WHO released the most recent maternal mortality estimates compiled with our UN colleagues and partners. The new report tracks maternal deaths nationally, regionally, and globally from 2000 to 2020. In 2020, an estimated 287,000 women globally died from a maternal cause. We invest in technologies that monitor the temperature of a toilet seat in a world where nearly 800 deaths per day occur, or 1 in every 2 minutes a woman dies, still related to pregnancy. This number has barely shifted since 2015. Millions of women still cannot access the right care when they need it, mostly women in the poorest countries and communities. Maternal mortality is an outcome for which we see very big inequities, which raises important concerns around access to high quality, respectful care and sexual and reproductive rights and autonomy. The MMR in sub-Saharan Africa is 545. This is 136 times bigger than the MMR in Australia and New Zealand. A 15-year-old girl in Chad has a 1 in 15 chance of dying from a maternal cause during her lifetime, which is over 4,000 times greater than the probability in Belarus. Many of the countries with the highest levels of maternal mortality are those in humanitarian and conflict settings. Friends, roughly a third of women globally are not able to access 4 of a recommended 8 antenatal checks or receive essential postnatal care in the days and weeks after birth. Some 270 million women lack access to modern family planning methods, meaning they cannot necessarily plan their pregnancy. This is a stark reminder that it's time to double down on our efforts and commitments to maternal health. While there is an increase in women delivering their babies in healthcare settings, outcomes are not improving. This indicates that we need to increase the quality of care provided. We must invest in health systems, scale up efforts to train health workers, and ensure that they have the tools and medicines they need to ensure healthy outcomes. The leading causes of maternal deaths are preventable, yes, preventable, and treatable with community engagement and increased access to high quality and respectful health care. Health systems must be accountable for providing quality, respectful, and equitable care through a well-trained and supported workforce and well-stocked shelves. A quote from the Director General of WHO, Dr. Tedros Adhanom Ghebreyesus, is as follows: pregnancy should be a time of immense hope and a positive experience for all women. It is tragically still a shockingly dangerous experience for millions around the world who lack access to high quality, respectful care. So today, we invite all of you to be part of a discussion about why progress has stalled and, more importantly, what can be done. This is a timely subject as we prepare to celebrate the International Day of the Midwife later this week and to participate in the International Maternal and Newborn Health Conference in Cape Town on May the 8th to May the 11th. It's the first time this group has come together since 2015, and among lots of new information, WHO will also launch its new cause of death estimates. So for those of you just tuning in, whether on LinkedIn, Twitter, Facebook, or YouTube, welcome. We look forward to your questions and comments and a very lively conversation. Please be sure to ask your questions in the chat and to have them as much as possible answered live. And you can tweet them with the hashtag delivering uncertainty, all in one word. So, recognizing our collective responsibility, we have a great series of interventions to stimulate your brains and get you tapping furiously in the chat to share your thoughts, experiences, and creativity. You will hear about some innovative approaches to enable equitable access to critical services. And with that, I am honored to introduce our panelists. Robyn Churchhill is a nurse midwife herself and is currently the team leader for maternal health at USAID. Larbi-Mensah is maternity in charge senior midwifery officer at the Tema Health Center, a public health facility serving 19,000 people of all ages. Tema is a twin city of Accra in Ghana. Lastina Lwatula is Japaigo's country director in Zambia, the founder of the Zambian Midwives Association, and currently working on momentum, country, and global leadership in Zambia. Angela Nguku is the founder and executive director of the White Ribbon Alliance in Kenya. Her flight has been delayed, but I'm still hoping she is going to be able to join us. And Janhavi Nilekani is a development economist by training and now works in the field of maternal health. She founded Aastrika Foundation in 2019, which is committed to improving the standards of maternal care to ensure a healthy, dignified, and joyful journey into motherhood. And Vandana Tripathi is the director of the Momentum Safe Surgery in Family Planning and Obstetrics project at Engender Health, and she oversees this global USAID initiative to improve access to, quality of, and use of safe surgical services in maternal health and family planning. Thank you all for joining and sharing your experiences and perspectives today. So can we turn first to Lastana? So, Lastana, what has changed in Zambia, and why do you think the MMR has basically stagnated since 2015? And what is Momentum doing to address this challenge in Zambia? Over to you.
Thank you so much for having me this afternoon and for inviting me to participate in this forum. What has changed in Zambia since 2015 is that we have seen an increase in the numbers of women dying. In fact, as I'm sitting here, we are experiencing a loss of 14 to 16 women dying every week. And the reporting itself has increased quite a lot because it is being done through MPDSR every week. And hence, we have seen also that, women are also presenting themselves in health facilities for deliveries rather than delivering in the community. So this has enabled us to collect real-time data so that we are able to report accurately and efficiently, although there is still a lot of room for improvement. In terms of, where we are, why it has stagnated is because we have a lot of challenges. challenges such as, systems barriers. We have a shortage of midwives, obstetricians in the country, and also even lack of the basic skills that can attend or respond timely to obstetric emergencies when they occur. At the same time, we do have other challenges such as the lack of commodities and also basic equipment in some of these facilities, coupled with distances. Most of our people in rural areas, Zambia, you may be aware, Zambia's population, 65% of Zambia's population lives in the rural areas, and hence, the terrain to get to health facilities sometimes can present a challenge. And therefore, some women, come to the health facilities when it is too late, indeed, to, receive quality emergency care. Others maybe deliver even on the way. And in terms of momentum believes, that no woman should die while giving birth, regardless of where they live. And so we are working with the Ministry of Health very closely, also with other partners, to ensure that women and children, get quality care where nearest to where they live. Therefore, we are working closely with Ministry of Health to ensure that we strengthen systems to skill the birth attendants, whether it's a midwife, doctor, or nurses, to ensure that the AMOC skills are delivered to the healthcare provider to prepare them to respond to these emergencies. At the same time, we are working with other partners who also provide other, other facilities to make sure that we collaborate and also prevent duplication of effort. The other thing that we are doing is we are working with the communities to strengthen community structures, working through the chiefs as well as the neighborhood health committees, making sure that we identify and also train, safe motherhood groups, as well as, ensuring that, they are ready to identify women and girls within the communities who may be in the reproductive health, way, so that they can bring them to the health facilities to seek care. Also, one other aspect that is very important is dispelling myths and misconceptions. For example, women do not want to seek antenatal care during the first semester because there are beliefs that maybe the pregnancies may be stolen. And so we work with within the communities, because community health workers are trusted by the communities because they live within the community and therefore, are more trusted. And also, lastly, I'd like to mention that issues of, commodities and supplies are another area where, healthcare workers find it difficult to deliver quality care. And so as Momentum, we do respond to such needs in the healthcare facilities that we work in, working across the continuum of care from community to facility and facility to community. Thank you.
Thank you very much for that. Please stay online. There are a few things that you raised that I'd like to double back on, but it's really nice to hear about Momentum's work, particularly those examples that show that it is possible to make a difference. Janhavi, if I can come to you next. Aastrika Foundation is committed to addressing the quality of the supply as well as the demand for professional midwives. Please share with us what you're doing to strengthen the capacity of midwives to deliver quality, respectful care, increase the number of professional midwives, and encourage the community to seek a professional midwife for their care.
Sure. Thank you so much for having me here today. I work in India, where I live as well. And, in India's maternal health landscape has three major challenges. One is what the Lancet series called the too little, too late challenge of inadequate access to healthcare workers or facilities or medicines or appropriate intervention. And because of that challenge, India still has high infant and maternal mortality rates, particularly in some regions. At the same time, we are also facing what the public health community calls the too much, too soon problem, where particularly in some areas. So, for example, even if you think cesarean rates should be maybe 10, 15, 20, 25%, there are 3 states in India with private sector cesarean rates which are more than 80%, 80. So that is the scale of which we are seeing a lot of unnecessary cesareans in India. And like in many other countries, India also faces a challenge of disrespect and abuse being pretty rampant across the country. So Aastrika Foundation is a true believer in professional midwives and the midwifery principles being a solution to some of these challenges. So midwives, on the one hand, by being trained healthcare providers, can help alleviate shortages of healthcare workers and improve maternal and infant mortality rates. But also because they are specialists in normal labor and birth, they can contribute to the reduction in the sky-high rates of cesareans in India, in parts of India rather. And of course, they provide respectful, gentle maternity care as part of their core mandate as midwives. So because of all the international evidence supporting midwifery, India is making an effort now to introduce a cadre of professional midwives who are trained to international standards set by ICM, the International Confederation of Midwives. So we at Aastrika Foundation are part of a coalition which includes the central government, several state governments, the Bill and Melinda Gates Foundation, the WHO, UNICEF, UNFPA, Fernandez Foundation, the White Ribbon Alliance of India, JAPIGO, and similar. All of us partners have come together to establish a network of national midwifery training institutes in India, where international midwifery faculty and experts have been coming to India to train experienced Indian nurses and nursing faculty to become midwifery faculty. And the next step would be for them to go on and staff midwifery training programs where we can train midwives. So Aastrika Foundation has established the National Midwifery Training Institute in Karnataka, which is one of India's southern states. I've also established a midwife-led care unit in the Karnataka's biggest government hospital. It has about 18,000 deliveries in a year. So it's a large hospital where we have established a midwifery-led care unit in order to train these midwifery faculty. One of the things we have found is that in a setting like ours, where we are training experienced nurses, then they often have the clinical skills, but they need a lot of immersion into the values of mother-centric care, of respectful maternity care, of gentleness, and of all of these softer aspects of providing high quality and respectful care to each and every mother. Aside from ensuring that in these midwifery programs we run to train professional midwives, Aastrika Foundation is also trying to improve the capacity of all cadres, doctors, nurses, nurse midwives, all the established cadres in India to practice high quality and respectful care. We do a range of training programs, and in particular, we use multiple learning methodologies, what are called andragogies, from role play to simulation to theory classes to classroom to mentorship and case studies, a whole variety of techniques. We run a digital learning platform called Aastrika Sphere, which has multiple courses on respectful maternity care, which are actually freely available to anybody who logs into the website. So we do a lot of supply side work, both to increase the number of professional midwives in India, but also to ensure that all nurses and other cadres who are part of the care of pregnant women, improve their skills to quality and respectful care. Finally, we do a fair amount of advocacy work to both establish the need for high quality and respectful care, to establish the idea that disrespect and abuse is truly intolerable and needs to be stamped out both in India and worldwide. to create awareness of the harms of overtreatment. Even in cities or districts with 70 or 80 or 90% cesarean rates, there is very little awareness of the potential harms of such a high level of excessive surgery. So along with all our advocacy work, we also have set up multiple centers of excellence to practice midwifery care. Specifically, aside from one in the public hospital, we also have one in the private sector, in the premium setting, to establish what can high quality, respectful care look like in the private sector, and what is the importance of midwifery even for mothers who are in the private sector and not in the government sector. So we're excited to do our work, and I'm really eager for the rest of this discussion today.
Fantastic. I think that it's really nice to the new things that I'm hearing from your presentation. Sort of new is really the value that is put on partnerships. This is something that we often don't hear about specifically within the context of training. So I think that is really good to hear, as well as the increase in the emphasis on respectful care all the way through. Vandana, if I can come to you now, please. If I can, what else will it take to reduce maternal mortality? What are we learning specifically from your safe surgery work?
Thanks, Pascale. And first of all, many thanks for the opportunity to join this panel of midwives and people who care very much about the work that midwives do. To your question, reflecting on the experiences of momentum safe surgery, and in particular, our work looking at adverse outcomes from surgical obstetric care. And I want to thank Janhavi for flagging that unnecessary surgery carries consequences as well that we want to avoid. I'd like to start by just saying that if we want to reduce the number of maternal deaths, we do have to look beyond just the number of deaths. In other words, every maternal death is a tragedy. And as you said at the beginning, the vast majority are preventable. Turning our attention to maternal and newborn morbidity is an important, and I would say a crucial way to get the information that we need to reduce both deaths and serious morbidities. We always say that the number that's always been said is for every maternal death, 20 to 30 women experience a serious morbidity, right? A disability, other injuries, infections. And so whether we're calling that maternal near miss or severe maternal morbidity or something else, I think our experiences with this project show us that reviewing these cases of morbidity can give us so much information on quality of care, missed opportunities for a timely referral, delays in care seeking or complications management, or those workforce and equipment gaps. And this information, we think, can drive a more timely and more localized response to strengthen maternal health care. Every maternal death is one death too many, but they are still rare events. So we get those population-based numbers on maternal deaths less frequently. We rely on data collection and estimation approaches that are expensive and they're episodic. We need, of course, that information on deaths, and that's why we're here together today to reflect on the recent numbers. But if every high-burden country could also collect, analyze, and act on information that's available from these instances of maternal morbidity, I think we can act faster and in a more targeted way to improve care. So we're really urging, as this project and I think our partners are seeing, that we can work together and we need to work together to standardize that measurement and reporting of maternal morbidity the same way we have for deaths through processes like what Lastina referred to, the maternal and perinatal death surveillance and response. So in our project, for example, we are looking at ways, cost-effective, low-burden ways to monitor outcomes even after discharge following surgical obstetric care. A lot of the things that may contribute to serious long-term injury or potentially to later maternal deaths are going to happen after a person's gone home. So what kinds of systems can we set up to actually collect, to know that those are happening, to monitor those outcomes and do something about them? The second point on my mind today is also coming from reflecting on our project's design. We were intended and mandated, in fact, to think about the needs and opportunities to strengthen surgical care across both obstetrics and family planning. And I think this work has convinced me even more that if we're going to reduce maternal deaths, we desperately have to break out of the silos that we find ourselves working in. I've been talking a little bit about breaking the silos of just looking at deaths versus, just mortality versus just morbidity. But I want to talk quickly about two other silos that I really think we need to break out of to move faster. First, with the renewed and critical attention to primary healthcare systems that we see now, we need to be careful to avoid silos between different levels of care. Maternal and newborn healthcare is primary healthcare, right? No matter if some of the life-saving aspects of it are delivered at facilities that are not PHC facilities. So let's not forget that in financing and strengthening PHC facilities, across levels of care have to be connected in strong referral networks, and those emergency newborn and obstetric care facilities also have to be strong and ready to receive the women and newborns that are coming to them from PHC facilities. I think the other silo that's on my mind all the time in this project is the silos that hinder real integration of maternal health and family planning service provision. We know, right, that a huge proportion of maternal deaths are still coming from unmet need for family planning. So let's break down the barriers that still make it hard to provide immediate postpartum family planning, for example, whether that's because contraceptive commodities are not in the maternity ward, or maybe because family planning is not part of the service of maternity care packages, or the packages of maternity services that might be covered by insurance schemes. And so one example of trying to address that is to really look at midwives as the key players also in that immediate postpartum family planning provision. And so in countries like Mali, for example, we're helping to train midwives at very high volume facilities in immediate postpartum family planning, providing them with the equipment and the kits they need to actually do it, and strengthen their role in that piece of reducing maternal deaths. I do want to end by saying it's easy to say this, but breaking down these silos usually or often means adding to the scopes of work of midwives and other people involved in providing maternity care. Integrated services can mean more work for each individual midwife. Task sharing can mean more work for that provider taking on those shared roles. So I think the last point I'd want to make is that we need to always be considering how we can support that workforce so that they can continue to provide the life-saving care that they do well. Thank you.
Thank you very much. You raised some really important points. I think that really push us to a systems thinking approach. I really love the emphasis on making sure that we're better at integrating the areas that we do. The mention of data, always music to my ears. It's absolutely critical that we, as you say, move from just counting deaths to actually looking at being able to monitor what it is we're doing and doing well, to be able to further support it. Robyn, if I can come to you next. The quality of care, since we've moved, this is a very nice segue into kind of the systems and care. So let's discuss quality of care. What is the real issue behind improving quality of care? Where should we invest, and how do we support midwives and other healthcare workers to provide women-centered, respectful care?
Thank you, Pascale. I want to start by saying that I love this panel. The wisdom, the breadth of perspective, and so many midwives. Wow, this is a treat. So we are 7 people, and none of us has all the answers. There's not a single solution, but together, by listening to these midwife voices and by including others in the conversation as well, we can get closer. So maternal mortality is the canary in the coal mine. Our systems are failing women and their children. Women are given birth without respect or dignity in the US, the UK, Haiti, Kenya, India. This has to change. At the recent PPH summit, we acknowledged a global failure to move the needle on postpartum hemorrhage, the #1 cause of maternal death. Even with greater availability and recognition of the importance of uterotonics and TXA, they're still not available everywhere where they're needed. We learned about the impact of poor diagnosis of postpartum hemorrhage and the role of anemia on mortality. Our efforts and focus are needed here to make a real difference. The Lancet Commission on High Quality Health Systems showed us that more deaths occur from receiving poor quality care than from poor access to care. And in fact, women are 50 to 100 times more likely to die of C-section in sub-Saharan Africa than they are in a high-income country. So what does that tell us? Well, we need to address equity, quality, and compassion in every aspect of the health system. We need to measure and address morbidity, as Vandana has said, as well as mortality. And we need to support mental health needs as well as physical health needs. Stagnating global progress in maternal mortality is disheartening, and it's also a human shame. Statistics are not just numbers. Every individual number is a mother, and nearly every death affects a midwife. So I'm an American midwife at USAID, but my midwife power is listening. So that's what I try to do. I'm listening to the 22-year-old Ugandan midwife who shared about a recent maternal death from postpartum hemorrhage. She knew what to do. She's a skilled midwife. She wanted to give oxytocin, but there wasn't any. She called the ambulance for an emergency referral, but nobody answered the phone. She called her facility director. He was away on leave. So she was left alone at night in the dark with a woman who didn't need to die. She held her phone in her mouth for light as she did bimanual compression, with blood pouring down her arm and tears running down her cheeks. That is not just a statistic. If we don't support that midwife, it is a fast route to burnout, and we will continue to fail. I'm also listening to the senior midwife in Malawi with so many patients in labor that she rarely has time to check in on the postnatal ward, where a woman sometimes dies. That death is not just a statistic. It reflects a system that does not prioritize a woman's life or a midwife's skill. I am listening to eager midwifery students in Sierra Leone who say we are committed to saving lives, but please, we need to be paid. In a country with one of the world's highest maternal mortality rates, these midwives deserve hazard pay, not just hope for a salary one day. I'm listening to the midwives in Zambia who claim stockouts of uterotonics and expired magnesium sulfate as a valid reason for referral because women deserve quality care. I'm listening to the brilliant midwife mentors in Ethiopia teaching and modeling high quality, respectful care with patience and compassion. And what I'm hearing loud and clear is that quality requires us to invest in the people in the system, in the midwives, in the frontline health workers. USAID's new PCMD framework, which aligns with the US government-wide Health Workforce Initiative, identifies the health worker gap as one of the leading barriers to achieving our shared global goals. We are directing investments to support these primary healthcare workers. And how do we do that? Historically, that Ugandan midwife would be offered EMOC training. But if we really want to support her, she needs oxytocin, she needs a responsive referral system, and she needs lights. We know the value of providing respectful, dignified care, and there are excellent mentors who can demonstrate that. But when a midwife hasn't been paid, is stretched too thin to see all of her patients, and is scrounging for the last likely expired magnesium sulfate vial, how do we ask her to spend more time listening to the women in her care? We can't just invest in simple activities. Our investments go further when we address the system gaps as identified by these midwives, rather than providing another training to a midwife who can't put it into practice in a poorly functioning system. Foundationally, quality happens at a local level, but it needs to be supported across the system. And we must demand quality at every level. Pascale, we have to insist that every global maternal newborn health target include quality, not later, but now. Coverage of services saves lives only when it's coverage of quality services. And then we must hold ourselves accountable to those quality targets. It's our collective responsibility, mine, yours, policymakers, funders, ministers of health, district health officers, ambulance drivers, primary healthcare workers, and of course, midwives. We have to collectively invest in the people who form the backbone of primary healthcare systems, because when they work together and interact in effective interdisciplinary teams across intentional networks of care linked by effective referral systems, when they are well-resourced, well supported and connected, and when they have light. These are the people who can solve the problems on the ground and provide quality care. We must invest in these problem solvers, in these midwives, and strengthen the systems around them and for them. Midwives must be on leadership teams, they must inform policy, and they must be at the table. I am so grateful they are here today, and now we need to listen. Thank you.
Awesome. Thank you so much, Robyn, for that, and for bringing a real dose of reality and such moving examples as well, to really kind of illustrate that we can. This is all doable. It's not where we are talking about preventable deaths, and we really should step up the efforts. We're not asking for high tech, we're not asking for technologies, we're asking for investment in people, and we're asking for high quality services. So on that note, Ruby, as I mentioned, you're in charge at the Tema Health Center. I'm from Ghana as well, so delighted to have you on the panel with us. It's a public health facility that serves a population of 19,000 people of all ages. And I understand that you have not recorded any maternal deaths in your clinic since 2018, which is a performance way above any that I've heard in a long time, and it's a wonderful accomplishment. So Ruby, what did you do? What's the secret to your success?
Hi, everyone. I'd like to say thank you to Momentum and USAID for giving me this opportunity. And I'm so happy everybody is talking for the midwife today. I'm so happy. I'm so overwhelmed. What I and my colleagues came together to do was to have a deba and making sure all the stakeholders in the community were part, going to the mothers, talking to them and having a dialogue with them, how best they can utilize the facility so that we wouldn't get any maternal death in our catchment area. So we started by identifying the problems. We knew accessibility to the facility was an issue. Then also anemia was also a factor to having maternal death. Then also making the antenatal and the labor ward conducive for the mother to utilize the place. Then also involving the spouses or the family as a whole. I'm happy, Pascale, Ghanaians, we value family more than anything. Family is all. So we actually incorporated the family into the antenatal. Then also we did it in such a way that we actually made it that we have mothers who visit the facility on first trimester. We have a days for them, second trimester, third trimester. Then I had a special class for the teenage mothers so that they will feel comfortable. They wouldn't go and do something that they are not supposed to do, so that they can come and access the facility. So these are the measures we put into place. Then we identified that anemia is one problem with most of the mothers that come in. So what can we do to make sure anemia is actually brought down at all? If possible, by 36 weeks, we shouldn't have any mother suffering from anemia. And realize where I am in Committee 1, most of the mothers are market women. So the resources were there, but how to use it was a problem. So in collaboration with the community health nurses, with the nutrition officer, we came up with a quarterly food bazaar. So the quarterly food bazaar is the mothers come together with their own green leafy vegetables, with their own plant protein, with their own cereals. They come together to prepare a meal which is nutritious, that is the 4-star diet, so that they can eat. So that when you go to the market, the little that you have, you can purchase this. I'm going to get this nutrients out of it. Let me purchase and add all together. I'm going to get the adequate diet, which is good for me as a pregnant woman and also good for the mother also and the baby. Then the family also can also enjoy the meal per the money that you are having. So that's what we came about. And since 1998 till date, it's still running, and it becomes excited every year. The mothers, you'll be overwhelmed. They come out with new ideas how to make the food so sumptuous that at the end of the day, you'll be eating a meal, you ask, you use this cereal to prepare? She said, yes, we use this, we added this small fish, we added this, that they incorporated everything, and the meal is so delicious. Then we realized also that because most of them are market women, at the same time also they go to market as early as 5:30 or 5 a.m. and they get home as late as 8 p.m. So what else can we do to actually also encourage them so that anemia wouldn't happen? Then we talked about malaria in pregnancy, because that late hour, when she's a pregnant woman, definitely mosquito bites where she finds herself. I hope Pascale knows Temacomti one very well. So then she will understand what I'm saying. The mosquitoes there, actually you'll be surprised. So we encourage them, aside you sleeping under your treated mosquito net, and we giving you the prophylaxis, it's best you use an applied mosquito repellent on your skin immediately after 4 p.m. Also, don't sit there that long up to that 8 p.m. At least by 5:36, you should be able to leave. Then most of the market women are friends anyway, so you can leave your goods with your friends to actually finish, close it up for you, so that tomorrow morning you can come. And it's actually working perfectly. They understand each other so much, because when the friend is not well, they wouldn't be happy. Then we also added exercise to it, so that every quarter we have an exercise that will march from the facility all the way to the market, around the police station, back to the facility. One, we do this reason we want to actually hammer to people that we are still in existence. Pregnant woman can get pregnant. She can have a healthy pregnancy. She'll look good in a pregnancy, not necessarily if only she continues to do one or two. Then also make everybody be aware in community, one, that there's a government facility that is so affordable, but we are giving quality care, that your wife or your sister can actually access that quality care from trained midwives. You don't need that extra money to have it. All you need is your NHIS. Visit the facility and we are ever ready to actually serve you. Then we also came up with letting the husbands or the partners be part of the pregnancy. So these are small incentives we came with. We encourage them. When you come with your husband, we are going to take care of you first, so that your husband can go back to work. And I'm telling you, it's working like magic. There are days I have about 80% of my mothers with their spouse. Then I said, okay, so who came first? We are going in turns. And it's so exciting. Both men come for our pregnancy school. They join us in our jogging. They join our, especially the food bazaar and the exercise. The men really love it, because they'll tell you, my wife is always actually lying down. She'll tell you, I just walked here and here, it's okay with me. But when they follow them to the quarterly exercise, the woman is able to go through the aerobics, which on 20th of May, I wish everybody would come to Ghana and come and watch. We are having our quarterly exercise, which is 20th of May. I wish everybody will come and see what the little that we are doing in that small facility with a lot of people. But we are adding our quota as midwives to make sure our mothers are full of life. They go to delivery, antenatal, postnatal, everything successfully. Then after 6 weeks, we hand them over to the child welfare clinic. That is the community health nurses or the public health nurses in our facility. And once in a while, they come back to us, especially every year. We have some sponsors who come together to help us to have a get-together for all mothers. We've taken care of them for 1 year. And based on that, people hear of us, people come, people want to see the magic we are performing to have a zero maternal death in the facility. It's not that much, but we actually made the mother our priority and the family. We never took any decision without them. We give them the privilege. Tell us, what do you want us to do? They bring the ideas, we modify it so that healthily all of us can work hand in hand and have what we actually want to achieve. 1, zero maternal mortality death. 2, partner support. 3, do things that at the end of the day, the community as a whole will benefit. And finally, Ghana Health Service, MOH, will also benefit from it. Thank you very much.
Great. Thank you so much, Ruby. I think it's really nice just hearing, I think the major take-home message from what you just shared with us. is moving the whole idea of maternity care outside of something that is clinical to really treating the woman as part of a community, as part of a family. And it breaks down all of the issues that have been raised also about silos and so on, that it's patient-centered. It is about what's in the very best interest of the woman, and to ensure the outcome of the pregnancy. I think, unfortunately, we have not been able to be joined by Angela. So I'm going to open up to the questions that are filling up in the comments section. Keep them coming, and I will start off with the question from Maleng Herbert. What efforts have Momentum exerted to address the social determinants of maternal and infant health? And I will ask Lastina, please, if you'd like to give it a shot.
Thank you very much, Herbert, for asking this very important question about social determinants. Of course, we know very well that health is, dependent on other factors, and these can influence negatively or positively the health outcomes of, a woman and her child. So what we are doing is that we are strengthening community structures to ensure that they become responsive to the health needs of the women and also families in the communities where they live, such as dispelling the myths and misconceptions. As I earlier, stated, women do not go for early antenatal because the belief is that, they will steal the pregnancy. And so we try to work through these communities to make sure that, the NHCs, which are the neighborhood health committees, as well as, other gatekeepers within the communities, such as the safe motherhood groups and, others, are aware of these, and we do conduct trainings on how best they can, dispel these myths and conceptions. And also we engage ourselves in a lot of advocacy activities to make sure that, the same, safe motherhood groups that are within the communities drum up, demand creation for women to come to the health facilities to receive, either antenatal care or indeed care during delivery. And some of the health facilities are very far in terms of reach to communities. And so we make sure that the community health workers connect these mothers that are very far off to the health facility, so where they can go and deliver. And they do have, boarding houses in these, health facilities where the mother can go in and wait for delivery. But also coupled with that, we work with the families, such as, the husbands and other, immediate or extended families, to make sure that the woman prepares for labor and delivery. And so that, they have the package and also other, things that they may need, such as transportation, so that when the day comes, people do not have to start, running around, but that they are ready. And then we also make sure that, at a very high level, we engage, the districts, and also working through the chiefs that are, the major gatekeepers of these communities. Because once they understand, what is required, it's easier for them to influence the communities to respond. Thank you.
Great, thank you very much. Can I ask Janhavi, please, if you don't mind commenting on a question from Lara? How are communities advocating and working with health systems to address maternal deaths? This was Janhavi, or is
It's
Ruby?
Ruby.
Did you want
Yeah,
to?
it's
Yes.
Ruby. Yeah. Okay, so thank you very much once again. Community advocacy. So what I'll say, what I use in my facility was one, bringing all the stakeholders. So you involve the chief imam, you involve the community health nurses itself, you involve the church leaders around. Then the market women, they have their own president because most of our mothers, they are market women. Then the community volunteer. So first we went around to do sensitization, one, to actually let them know, oh, the facility is back, we are working, we need everybody to come on board. We want to have a deba with you so that your grievances, reason why you are not using the facility, just let us know so that we'll take it up from there. And we had a deba. When we had a deba, the community members also had their own issues that they want us to also tackle as health workers. That will make the place conducive for them to actually allow their wives, their sisters to actually use, their daughters to use their facility. We came back as a facility, had our own deba, our staff deba, spoke about the issues. Then training was done on how to actually handle patients. So quality care, when they come in, you should be in their shoes. You should try to understand them. And we know the work we do, there will be one or two occasions, but as much as we can, we should control ourselves and give the quality care. That's why we are here, is because of the patients. Even though if there is a language barrier, make the patient comfortable. Try as much as you can. Maybe a colleague of yours understand that language. You call her so that she'll be your translator. Then you encourage the patient also. Next time when you are coming, bring somebody who understands you, who also understands us, so that we can all communicate. So when you involve the community, it makes your work so easy. They'll rather go around making the noise for you so that the people will also use the facility. But the first thing is to have a deba with the community. And when you have it, the advocacy will go far, 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 because they will be spreading the news about the facility, the quality care that you are giving, how responsible the health care givers who are working in the facility, and what to expect when they visit the facility. So that is how I did in Tema.
Great. Thank you very much. Again, I really appreciate the nature of us taking the maternal health issues, not just as a clinical issue, but something that really does involve communities in a very practical way. There are lots of questions coming in. I am going to take chair's moderators action. And ask if there are two issues that I think are quite important that have been raised. And I'll leave it open to any of you to respond to this. One is the issue of resource allocation and how to involve the various district level, given it's a health systems issue. Maybe Robyn might be able to address this one. But how do we work within the district health system? That's one. And then the second question possibly is where do technologies fit into this? Because regardless, we are moving very much into a technology age. So with I guess around safe surgeries and so on, where do you see the role of technologies in this? If we can get some very quick responses to this, and then I'll come back to each of you to have your 1 minute quick fire round for your main message to wrap this up. Any takers on the working with district health systems and resource allocation? Was a question from Juan Carlos. Yes. Robyn, please.
Sure. I think that there's a real need for community advocacy, but to help coordinate and make sure that these voices are not just one-offs, but really have a shared voice. In the Global Safer Together campaign, which was based on women's experiences and demands, that was actually launched with some critical messages to women. And I feel like I'm stepping into Angela's space with her not here. But the What Women Want campaign is another example where there are some good targeted messages, listening to women and then helping them turn that into action. And in Nigeria, the Niger state government released long withheld primary healthcare funds to 171 facilities in response to this campaign in Nigeria. I think these are examples. In Malawi, a similar social action came about in demanding midwives, and the Malawian government actually invested in, I believe, 1,000 more midwives to be educated. So I do think that there are really good examples of advocating for the release of funds or of better investments with governments at various levels. But I think it takes that collective action. It takes listening to the voices. It takes elevating the voices and focusing them. But I do think there are some really good examples of that.
Thank you, Robyn. And Vandana, can you take the question on technologies and where we are?
If I can build on Robyn's comments, is two of the questions that came in are really linked, and it's this community advocacy piece and then this good practices at the district level. And I just wanted to share an example that I think connects the question from Juan Carlos with the earlier question on that a model that we've used with success at Engender Health in many settings, from Uganda to Guinea to Niger, is what we call the site walkthrough. And it's literally bringing the community into a health facility, into a maternity facility, to look at it, to bring community leaders, traditional leaders, elders, formal government, local government folks, and say, this is what are the services here? This is your facility. And actually use this walkthrough to generate community action planning and say, well, what are the gaps that have most hindered your experience of care, that have made care seeking cumbersome, unwanted, undesirable, and to use that to develop district level action plans for resource allocation, for advocating for more staff, for more resources. But it's this way of connecting the community to the system, to the facility, so that that first experience is not in a moment of crisis or in a moment of urgency, but in a planned way. And I think that question really bridges to strengthen things at the local level. The community and district health management teams have to be connected to each other. So I wanted to add that thought. And someone else may have something to say about technology. Although I think one of the nicest things that we're seeing is all of the ways that low effort technology, WhatsApp user groups, for example, are giving us a way to connect providers directly to each other so that referral networks can function more quickly, that a sending facility and a receiving facility are talking to each other for timely care. But I think others might have more to say on more complex technologies and solutions that are emerging. Thanks.
Great, thank you. I'm not sure if we should keep going. I'm happy to go for another 15 minutes or so. Keep going, okay. Did anyone else want to pick up the question on technologies? If not, we can go to one of the other questions that has been raised. I will pick, quite a few. It does go to, there are several questions about AI and the possibility of supporting midwives through new technologies again. Maria, are there tools designed or being implemented to gather the patient perspective of their experience of maternal care? How can we feed back patients' experience into improving their quality of care? So this links up the different ways of collecting data, but also ensuring the patient-centeredness of the work. Any takers on that particular one? Yes. You're muted.
So this is something we work on quite a bit, especially in the Center of Excellence, as I mentioned, that we're trying to really demonstrate what high quality care can look like in specific facilities. Because at the end of the day, though, however much we may talk about it or have some idea, it's hard to change minds in your vicinity without them seeing concrete examples in front of them. You know, even very simple things like international guidelines may often be dismissed, saying, okay, no, there's no example from India, Indian women are different, and so forth. So we spend a lot of time doing in our Center of Excellences trying to improve quality of care, very much including patient perspectives. I think more than complicated tools, this is my view, but more than specific tools, or it's more important to routinely collect the feedback. We have in-house questionnaires. The ICI initiative set up by FIGO and ICM, they have a lot of questionnaires on patient experience. So does the University of Gothenburg. There are several institutions which have gone to the trouble of developing childbirth experience questionnaires. There are some printed in academic literature, but I think more than using any specific tool over another, what's important is to have it in your system flow in the facility, that collecting feedback from the mothers, from the family, is a routine part of your process flow for each and every family that goes through your unit, and to ensure that there are systems of auditing as well. There is no use in collecting feedback unless there is a system where management, doctors, nurses, midwives, everybody has a process of reviewing that feedback and then acting on it. So I think for me that would be the key answer, that to pick there are several tools, but to pick a specific survey or questionnaire feedback form, and then whether digital or paper, I've seen both, but then to be diligent about utilizing it routinely and paying attention to what the answers are.
Great, thank you. I do think that this is an important one to pick up, because if we are talking about giving patients much more of a voice and having the data to be able to monitor quality of services, because we do need to pay a bit more attention to the services. I think it really is crucial that we understand, as if we're moving into kind of health system strengthening, how do we monitor that we're doing it right? Because it is, as I mentioned, a systems approach. There is so much in that space. So as kind of a complex intervention, we do need to find ways of trying to understand what is happening there. Now, I know, for instance, that HRP, a bit of self-plugging here, will be publishing a qualitative toolkit to support locally driven bottom-up research into women's experience of maternity care later this year. And that is an important piece. But I believe, Robyn, as well, you can address this issue.
So I think one of the things that I remember hearing early on is that you cannot replace a midwife with an app. And I think when we talked about technology, we understand that there are these shortcomings, that there are not enough staff, but you cannot replace a midwife with technology. You can facilitate the workflows, but you still need the midwife to be part of an interdisciplinary team. They need to be connected with the community. The community's voices need to be heard. We're doing some beginning work supporting the WHO on the networks of care framework, which includes the relational networks of care. And I think these components are really the crux of what makes a health system run. It's the connections between people, everybody, from the guard at the gate to the cleaner to the district health management teams, with the midwife managing the labor and the care. The community voices are really, that connection is also really important. I would love to, first of all, listen. I think listening is the number one job that we have. Listen to what the technology might need, what the problems are, and then solve it. Coming in with the solution without understanding the problem is not helping. Having a long-term plan for sustaining that technology, and as USAID, I understand we have program timelines, but there has to be a plan beyond the 5 years for that technology to continue, or it's just a game, and we can't spend any more time on games. It has to be meaningful. So I would say listen, connect, understand the problem, and then solve for that problem, potentially with technology. Thank you.
Excellent. Vandana.
Sure, thank you. And I'd love to follow up on Yami. I hope I'm saying your name right. Yami's questions about the experience of care. And one of the things, we've heard about disrespect and abuse. We've heard about the importance of respectful maternity care. And a point that I'd want to add is that the importance of the experience of care does not end at the OT door. And one of the things we've seen is a lot of evidence of almost no counseling before a cesarean section. Very little gathering of informed consent. Yes, of course, often these are emergencies, but that does not mean that there aren't opportunities, for example, in antenatal care, in care planning, so many stages of the way to talk to women and their families about surgical obstetric care, about cesarean, what might be involved, about the recovery. So we've just finished extensive mixed methods research to ask women, providers, family members, what does consent mean when it comes to a cesarean section? What is debriefing after that surgical intervention? And we've learned so much about the difference between a form that's signed and the actual discussion with a person who's about to undergo this procedure of what's involved. And what we're doing now through the Momentum Safe Surgery Project is looking at provider side and community and client side interventions to actually strengthen that experience of care and remember that respectful maternity care carries forward even when you have to have a surgical or an emergency intervention. And we hope that the tools that we are developing through this research and these responses can actually be shared broadly to keep improving that experience of care and to keep broadening what RMC means. So really appreciate that question. Thank you.
Excellent. Thank you very much for that. So we have about 7 minutes, and I would like you each to kind of provide us with your one critical message that you would like us to remember. Before I do that, in case I don't have time at the end, I do want to say, as a midwife, it's been a delight, and couldn't be happier to see that we have moved finally to a phase where the role of the midwife is recognized as critical to maternity care and having to be a part of this discussion, not just during pregnancy, antenatally, but also the issues that have been raised for the postpartum period. Again, an area that we will be casting a stronger eye on as well here in HRP, well-being in general, and being able to follow mothers up for a longer period of time, perhaps, than we have been looking at. But if I can start, and I'll go in no particular order of the way you presented, but if I can start with Lastina first, your quick message that you want us to take away from this discussion.
Thank you very much, Pascale. For me, I think that, previous efforts to reduce maternal mortality in Zambia has resulted in a reduction in community deliveries and also increased facility mortality. This has exposed gaps in the quality of care being provided at the health facilities. And for us to get back on the right trajectory, there is need for investment in new sustainable capacity building approaches, behavior change both at facility and community levels, and also strengthening the midterm evaluation framework process and working with local governments to improve the road networks and also availability of transport as well as commodities and whatever is required. Thank you.
Thank you very much for that. Ruby, what do you want us to take away from this discussion?
I'd like to say thank you once again for giving me this opportunity. And I wouldn't mind working or sharing the ideas that I have to other countries so that they'll also learn what we are doing in our small facility. I'm so happy that the midwife is at the center of everything that we are saying currently as at now. So I'm hoping that Momentum USAID will put in a roadmap and logistics, making sure that the midwife will bring out the best to save our mothers and our babies in the community as a whole. Thank you.
Perfect. Thank you very much. Janhavi?
Now, it was a complete pleasure to be here today. Some thoughts that struck me that, I really appreciated how much everyone was emphasizing on respectful maternity care. And something I really feel is that respectful maternity care and informed consent, while hugely valuable in and of themselves, also make a big difference on maternal morbidity and mortality because they affect health-seeking behavior from the mothers. We touched today on the points of the importance of antenatal care and repeated antenatal visits, not occasional antenatal care, on postpartum care, on ensuring that there's continuous follow-up. And all of that is far easier to achieve when women are comfortable and confident and feel safe in their healthcare facilities and are willing to seek out that care, and are far, far harder to achieve in settings where women are minimizing their interactions with the healthcare facilities purely for its lack of safety and respect. So thank you so much. It's been a pleasure to be here.
Thank you very much. Robyn?
Oh, that pesky unmute button. I think I would say we need to listen. And I think first and foremost, if we are talking, we are not listening. And so I always urge us to stop and listen. What we invest in should be informed by the midwives and the women and the communities who are, in fact, doing that quality care. I think we need to support the connections between people across the community, across the system, and across countries. I think the knowledge is gained in understanding and learning from each other. We are humans, we are social by nature. Even the most timid of us have connections. That also provides support. It is really hard to be a midwife in many of these communities. It is really hard to be a woman who is pregnant. And so I think having a support network, these are things we need to invest in. And finally, we need to invest in people. And for anyone who argues that it's too expensive to invest in people, I will point to public education. We invested in teachers around the world. It can be done, it must be done, and we have to do it. Thanks.
Thank you so much, Robyn. And Vandana?
Well, I think my colleagues have said it all, but I'll add two things to their wisdom. One is, we're so used in maternity care to thinking about the 3 delays, right? Deciding to seek care, reaching that care, and getting that care. There's a 4th stage, and it's what happens after discharge. It's all of the things that do and don't happen after a woman and hopefully her baby leave that facility. And so remembering the 4 parts, I think, of maternal care and newborn care is really crucial in reducing maternal deaths in the long run. But the last thing I'll say is, we've talked so much about midwives and how important they are, but so often they're working alone. And then so often when they're in a team, they're not listened to. So maybe the last thing I would say, that if we really want to improve the quality of care, the experience of care, and reduce deaths, we can encourage teamwork mindsets, teamwork training, things that de-emphasize hierarchies and actually encourage everybody to listen to each other so that the experience of care is improved for the patient, but also for the providers who have to stay strong and keep working. So I'll end with that thought, and thank you again for this opportunity.
Great. Thank you all very much. And I'd like to end by thanking Momentum USAID for organizing this panel. We really do need to think, given what the data show, that really we have to think about doing things differently. There's the reality is there is nothing new that has been raised. It is the big difference has been in the emphasis in the need to listen to people, not to think that the technology in and of itself will drive the answers and the solutions. This is about people. It is about working with our communities. We do need to listen. We do need to engage. So thank you very much, Momentum USAID, for organizing this. Thank you to the panelists, amazing, amazing women working in this space. Good luck to those who will be in Cape Town. Unfortunately, I won't be able to join you, but it is fantastic that we have the opportunity to regroup after such a long time to discuss where it is we are with ensuring that we have ways of moving forward to make a real difference in the maternal mortality statistics. They're just not good enough. Thank you very much.